Welcome to the deep dive. Today, we're getting stuck into a really crucial topic for your MSRA revision, diabetic ketoacidosis, DKA.
Absolutely vital.
Think of this session really as us helping you solidify your understanding. We want to make sure this critical condition is locked in for the exam.
Yeah, the aim is pretty straightforward.
Yeah.
Pull out the absolute must-know stuff about DKA from our notes, make it clear, hopefully a bit engaging, and definitely memorable.
Exactly. We'll be going through the whole lot: definition, causes, who's at risk, what's actually happening in the body.
Pathophysiology, yeah. And then diagnosis, management.
Prognosis, complications, the full picture. And, we'll try and drop in some mnemonics and memory tricks as we go.
Sounds like a plan. Let's get into it. DKA.
Okay, so kicking things off, what exactly is DKA? Let's nail the definition for the MSRA.
Right. So at its core, DKA is a severe, genuinely life-threatening complication of diabetes. It's a proper medical emergency.
No messing around.
Definitely not. And the key thing to remember, sort of the classic triad for the exam, is hyperglycemia, so high blood sugar. Okay, ketosis, that's the buildup of these things called ketones.
Right.
And metabolic acidosis, basically, the body's acid-base balance goes out of whack. It becomes too acidic.
Hyperglycemia, ketosis, acidosis. Got it. Now, you mostly see this in type 1 diabetes, right?
Yeah, that's where it's most common. But, and this is important, it can happen in type 2 diabetes. It's less frequent, but definitely possible, so don't rule it out.
Good point. So, in simple terms, what's driving this? What's the fundamental problem?
Well, it all boils down to a severe lack of effective insulin. Either there's just not enough insulin around, or the body can't use it properly.
Like the key isn't working.
Exactly like that. Insulin's the key that lets glucose into cells for energy. If the key's missing or broken, glucose stays stuck in the blood.
Okay.
So the body thinks, uh-oh, need energy, and
Yeah.
starts breaking down fat instead.
Ah, the backup plan.
Right. But burning fat produces these byproducts called ketone bodies. And if they build up too quickly, faster than the body can clear them.
That's the ketosis and the acidosis.
Precisely. They accumulate, they're acidic, and boom, you get systemic acidosis.
Okay, that makes sense. The body tries to compensate, but creates this toxic situation. So when someone comes in, what are the hard diagnostic criteria, the numbers we need for the MSRA?
Okay, the specific criteria are, first, hyperglycemia. That's usually a blood glucose over 11 millimole, or, importantly, just having a known diagnosis of diabetes counts here too.
Even if the sugar isn't sky high right then.
Potentially, yeah.
Yeah.
Second, you need evidence of ketosis. That's typically a blood ketone level beta-hydroxybutyrate greater than 3 millimole.
Okay.
Or you might see significant ketones in the urine, like 2+ on a dipstick.
Uh-huh.
And third, the metabolic acidosis bed. That's shown by a bicarbonate level below 15 millimole and our venous pH less than 7.3.
Right. So glucose 11 or known diabetes, ketones 3, bicarb 15, or pH 7.3.
That's the core triad. But here's a crucial nuance for your revision. Hyperglycemia isn't always dramatically high. You can have DKA without blood sugar being through the roof, sometimes called euglycemic DKA. And similarly, relatively low ketone levels don't automatically rule it out if everything else fits.
So you have to look at the whole clinical picture, not just rigidly tick boxes.
Exactly. Context is everything.
Okay, super helpful. We know what it is. Let's move to why it happens. What are the triggers, the causes?
Well, the root cause is always that insulin deficiency, absolute or relative. But usually there's a specific trigger, a precipitating factor that pushes someone over the edge.
Like what?
There's actually a pretty useful mnemonic for this, good for the MSRA. It's missed in.
Missed in. Okay, I like mnemonics. Break it down for me.
Sure. M is for missed insulin doses, probably the most common one.
Makes sense.
It is for infection, think pneumonia, UTIs, that sort of thing.
Yeah.
Infections increase stress hormones, which counteract insulin.
Right.
S is for stress, major physical stress like surgery, trauma, or even significant emotional stress. Second S is for surgery itself, as mentioned. E could stand for eating disorders or significant alcohol intake, which can mess with metabolism. D is for drugs. Drugs, corticosteroids are a classic example, but also things like SGLT2 inhibitors can sometimes trigger it, especially that euglycemic DKA.
Ah, the newer diabetes drugs. Good to know.
I is for infarction, like a myocardial infarction, or other serious illnesses like stroke or pancreatitis.
Wow. Okay.
And N is for new onset diabetes, someone who hasn't been diagnosed yet, so they have no insulin treatment. DKA might be their first presentation.
Missed in. That's brilliant. Missed insulin, infection, stress, surgery, eating ethanol, drugs, infarction, new onset. Covers a lot.
It does. And underlying all that is often just generally poor diabetes management or inadequate insulin dosing over time. For type 1s, delayed diagnosis is also a big factor.
Okay, so definition, check. Causes and triggers using Mistin, check. Now, who's most likely to get DK? What are the key risk factors to flag up for the MSRA?
We can kind of group these. Obviously, having type 1 diabetes is the biggest risk factor, especially if it's a new diagnosis.
Right.
Then there's inadequate insulin therapy, not taking enough, or poor adherence, missing doses. That's huge.
Uh-huh.
We mentioned intercurrent illnesses, particularly infections. They really ramp up insulin needs. Same goes for major physical or emotional stress.
Okay, so situations that increase the body's demand for insulin.
Precisely. But there are other factors too.
Mm.
Socioeconomic things can play a part, like limited access to health care or maybe difficulty affording insulin.
That's a really important point.
Yeah. And some studies suggest younger people, those from lower socioeconomic backgrounds and certain ethnicities like South Asian or African descent, might be at higher risk.
Uh-huh.
And remember, many of those missed-in triggers also function as risk factors.
Mhm.
Things like stopping insulin, intentionally or not, cardiovascular events, certain drugs we mentioned like steroids or SGLT2 inhibitors.
Thiazide diuretics sometimes too.
Yes, thiazides can also contribute. Physiological stresses like pregnancy, major surgery, trauma, even menstruation can be a trigger for some women.
It really seems like a complex interplay of factors sometimes.
It often is. A good way to remember this for the exam might be to build a quick patient picture in your head. Maybe a young person with type 1, maybe had a recent infection, perhaps struggling with their insulin regimen. Combining factors makes it stick.
Good tip. Picture the patient. Okay, let's get deeper into the biology. Pathophysiology. How does this all actually unfold inside the body?
Right, the nitty-gritty. So, as we said, the core problem is not enough effective insulin, combined with a rise in the stress hormones, glucagon, cortisol, adrenaline, growth hormone. These are counter-regulatory hormones.
They work against insulin.
Exactly. So
Yeah.
insulin normally helps glucose get into cells. Without enough effective insulin, glucose uptake is impaired. It builds up in the blood. That's the hyperglycemia.
Okay.
The body senses it's starving for glucose energy even though there's loads in the blood. So it triggers lipolysis, the breakdown of fat stores.
Plan B again.
Yep. This floods the system with free fatty acids. These go to the liver, which then converts them into ketone bodies, acetoacetate, beta-hydroxybutyrate, and acetone.
Those are the culprits causing the acidosis.
They are. Acetoacetate and beta-hydroxybutyrate are acids. As they accumulate faster than the body's buffering systems can handle, the blood pH drops. That's your metabolic acidosis.
And acetone.
Acetone is volatile. It gets breathed out. That's what causes the characteristic fruity or pear drop smell in the breath.
Oh, okay. So insulin, high glucose fat breakdown, ketone acidosis, plus dehydration from the high sugar causing osmotic diuresis.
Exactly. The hyperglycemia pulls water out of cells and makes you pee a lot, leading to dehydration and electrolyte imbalances. It's this whole cascade acidosis, electrolyte shifts, dehydration, hyperglycemia that causes the clinical features. Uncontrolled lipolysis and ketone production are absolutely central.
Got it. The body's response backfires badly. So when you see a patient looking like this, maybe confused, breathing fast, dehydrated, what else could be going on? What are the differential diagnoses we need to think about for the MSRA?
Good question. You need to rule out other possibilities. We can group them. First, think about other causes of ketoacidosis.
Like
Alcoholic ketoacidosis, common in people with chronic alcohol misuse and poor nutrition. And starvation ketosis, though that's usually milder.
Okay, other ketoacidosis types. What else?
Other causes of metabolic acidosis more broadly. Lactic acidosis, maybe from severe sepsis or tissue hypoperfusion. Then there are poisonings, aspirin overdose, methanol, ethylene glycol. They can cause a high anion gap metabolic acidosis too.
Right, the toxic alcohol.
Exactly. Then think about conditions with similar symptoms. The big one to differentiate from DKA is hyperosmolar, hyperglycemic state, HHS.
How do you tell them apart or quickly?
Key difference. HHS typically has much higher glucose levels, profound dehydration, but significantly less ketosis and acidosis compared to DKA. Ketones are usually low or absent in HHS.
Okay, HHS, high sugar, high osmolality, low ketones. DKA, high sugar, usually. High ketones, acidosis.
That's a good summary. Other mimics could be sepsis, presenting with altered mental state or shock, acute pancreatitis, which can cause abdominal pain and vomiting, MI, maybe even other acute abdominal emergencies.
So lots to consider.
Definitely. A helpful tip might be, if you have a patient with altered mental status, think about what initial tests help differentiate. A blood gas showing severe acidosis points more to DKA or lactic acidosis. High ketone screen DKA,
Right.
while extremely high glucose might suggest HHS.
Makes sense. Use those initial labs.
Yep.
Okay, let's talk epidemiology. How common is DKA? Who gets it? The bigger picture stuff for the MSRA.
Right. DKA is still a major cause of problems, morbidity, and mortality for people with diabetes.
Oh,
As
no.
we've said, much more common in type 1, particularly younger people. The actual rates can vary a lot depending on, how good diabetes care is in an area, access to health care, patient education levels.
Stands to reason. Better support, fewer crises.
Generally, yes. The good news is that mortality rates from DKA have dropped significantly over the last 20 years or so, thanks to better treatment protocols.
That's encouraging. Any specific numbers for the UK?
Yeah, the National Diabetes Audit gives some useful figures for type 1 adults. The annual incidence is around 3.6%, so roughly 1 in 25 adults with type 1 might experience DKA each year.
Okay.
Interestingly, about 6% of new type 1 diagnoses actually present with DKA, and around 8% of DKA episodes happen in people already in hospital for something else.
Wow, so it can catch you out even in hospital. What about type 2? We said it's less common.
Much less common than HHS in type 2, but definitely happens. There's a specific subset sometimes called ketosis-prone type 2 diabetes, often seen in older, maybe overweight individuals, often non-white ethnicities. For some of them, DKA can actually be the first sign they even have diabetes.
Really important point for the exam. Don't just dismiss DKA in someone thought to have type 2.
Absolutely not. Always keep it in mind if the picture fits.
Okay. Now, the clinical presentation. What does a patient with DKA actually look like? What are the key signs and symptoms we need to spot?
The onset is usually pretty quick, often over 24 hours or so. Early on, you get the classic diabetes symptoms ramped up, extreme thirst, polydipsia,
Right.
frequent urination, polyuria, then often abdominal pain, nausea, and vomiting start. That abdo pain can be quite severe. Then you get the really characteristic stuff, that fruity or acetone smell in the breath, and the breathing pattern changes. It becomes deep and rapid, trying to blow off CO2 to compensate for the acidosis. That's Kussmaul breathing.
Kussmaul breathing, fruity breath, classic exam clues.
Definitely. As things worsen, you might see neurological signs like confusion, drowsiness, altered mental status. General fatigue and weakness are common too. And clear signs of dehydration, dry mouth, dry skin, maybe sunken eyes, reduced urine output despite the initial polyuria.
Okay. And if it gets really bad?
Severe DKA can lead to low blood pressure, hypotension, a fast heart rate, tachycardia, and eventually coma.
So it's a spectrum from feeling unwell to critically ill.
Absolutely. A quick mnemonic for key features for the MSRA could be something like APE's key. Abdominal pain, polyuria, dipsy dehydration, Kussmaul respiration, acetone breath, and maybe E for altered encephalopathy mental state. The key is spotting it early.
APE's key. Abdo pain, polys, Kussmaul, acetone, encephalopathy. I like it.
The main takeaway is, any person with diabetes who is unwell needs their glucose and ketones checked promptly. Think DKA. On examination, they often just look unwell, toxic. You'll see those dehydration signs, check mucous membranes, skin turgor, cap refill. Assess their cardiovascular status pulse, BP. Smell their breath. Watch their breathing. Listen to their chest. Check their abdomen for tenderness or signs of infection. Do a neuroassessment. Look for potential infection sources on the skin.
A really thorough head-to-toe, looking for the DKA and the trigger. Okay, suspicion is high. What tests confirm it and help guide management? The investigations for the MSRA.
Right, the workup. Blood tests are central. You need plasma glucose, usually high. You absolutely need blood ketone levels. Beta-hydroxybutyrate is the one to ask for. It's much better than urine ketones.
Okay, blood ketones crucial.
Yes. Then electrolytes, particularly potassium. Remember, the initial level might be normal or high because of acidosis shifting potassium out of cells, but it will plummet once you start insulin. So baseline and frequent monitoring are key. Bicarbonate will be low, reflecting the acidosis. Check renal function, urea, and creatinine often up due to dehydration. Pre-renal AKI.
Got it. Glucose, ketones, UNEs, including bicarb, renal function. What else?
An arterial or venous blood gas, VBG often sufficient initially, is essential to confirm the acidosis, low pH, low bicarbonate, and check their respiratory compensation, low PCO2. Urine dipstick shows glucose and ketones, yes, but send a urine sample for microscopy and culture, MSU, to look for a UTI.
And you mentioned blood ketones are better than urine?
Yeah, much more sensitive and specific for monitoring the actual level of ketonemia in response to treatment. Urine ketones can lag behind.
Okay. Any other tests, depending on the situation?
Definitely. Full blood count, a high white cell count might point to infection, though stress can raise it too. Consider cardiac enzymes, troponin, if you suspect an MI as the trigger or complication. Creatine kinase if concerned about rhabdomyolysis. Amylase if pancreatitis is suspected. Blood cultures are vital if infection is suspected. Always get a 12-lead ECG checks for MI and potassium-related changes. Chest X-ray if respiratory symptoms or suspicion of pneumonia. Maybe an abdominal X-ray if the abdo pain is severe.
And imaging?
CT or MRI head scan might be needed if there's significant altered consciousness or focal neurology to rule out other causes or complications like cerebral edema. Lumbar puncture if meningitis is a possibility, but usually after imaging if GCS is low.
A comprehensive set of potential tests. What about things like osmolality and anion gap? Do they help?
Yes, they do. Plasma osmolality measures the concentration of solutes in the blood. It'll be increased in DKA due to the glucose and dehydration. It's usually much higher in HHS, though. That helps differentiate. A calculated osmolality above about 290 meals in kilonewton is typical for DKA. If it's over 320, especially with less ketosis, think HHS.
Okay, and the anion gap?
The anion gap is calculated usually sodium plus potassium, chloride plus bicarbonate. In DKA, it's typically high, usually above 13 millimole, because the ketone bodies are unmeasured anions contributing to the gap. It confirms that type of metabolic acidosis.
Right, so osmolality and anion gap add to the diagnostic picture and help differentiate.
Yeah.
Excellent. Now, the really critical bit for the MSRA management. How do we fix this?
Okay, management is all about prompt action and usually needs hospital admission, often to a higher care area initially depending on severity. The cornerstones are fluids, insulin, and electrolytes, especially potassium, plus finding and treating the underlying trigger. Think FEAT.
Fluids, insulin, electrolytes, trigger. FIET. Okay, let's break that down. Fluids first.
Right, dehydration is severe, so fluid resuscitation is priority number one. It restores circulating volume, improves tissue perfusion, helps flush out ketones via the kidneys, and starts to lower glucose a bit.
What fluid do you use?
Usually start with isotonic saline, 0.9% sodium chloride. Even if they're very acidotic, saline is generally the first choice. The rate depends on how dehydrated they are, their age, cardiac function, etc., but it's often quite rapid, initially maybe a liter over the first hour, then more gradually. There are specific protocols.
Okay, lots of saline up front, then insulin.
Yes, but usually after starting fluids for maybe an hour, unless potassium is known to be low. We use intravenous insulin, typically a fixed-rate infusion. A common starting dose is 0.1 units per kilogram of body weight per hour.
Fixed rate, not sliding scale.
Fixed rate is standard for DKA treatment. The goal is to switch off ketone production reliably and gradually lower glucose. Once blood glucose drops to around 14 or 15 millimole, you need to add dextrose to the IV fluids, usually 5% or 10% dextrose, while continuing the insulin infusion.
Why add sugar when the problem was high sugar?
Because you need to keep the insulin going to suppress the ketones, but you don't want the blood sugar to crash too low, hypoglycemia. Adding dextrose allows you to continue the insulin safely until the ketones and acidosis resolves.
Ah, okay. Keep insulin going, prevent hypo with dextrose. Smart. Now, electrolytes, you mentioned potassium being tricky.
Very tricky. Insulin drives potassium back into cells, so even if the initial blood level is normal or high, it will fall, sometimes dramatically, once you start the insulin infusion. Most patients will need potassium added to their 5e fluids quite early on.
How much?
Depends on the baseline level and subsequent monitoring, but it's often added to the maintenance fluids. You have to monitor potassium levels very frequently, maybe hourly at first, along with glucose and gases. If you need to get potassium at a rate faster than, say, 20 millimole per hour, the patient usually needs cardiac monitoring because high potassium infusion rates can cause arrhythmias.
So frequent checks and careful replacement, possibly with cardiac monitoring.
Got it.
And the T-trigger.
Crucial. While you're doing all this, you absolutely must investigate and treat the underlying cause identified by MIST. If it's an infection, start appropriate antibiotics quickly. If it's missed insulin, focus on education and restarting it safely later. If it's an MI, manage that concurrently.
Makes sense. Otherwise, it might just happen again. So how do you know when the DKA is actually better? What are the resolution criteria for the MSRA?
We're looking for the biochemistry to normalize and the patient to improve clinically. The standard criteria are usually blood ketones less than 0.6 millimole, venous bicarbonate above 15 millimole, and venous pH above 7.3.
Ketones 0.6, bicarb 15, pH 7.3.
Yes. And alongside that, the patient should ideally be clinically improving, able to eat and drink, and their underlying trigger should be resolving. Ketones often take longer to clear. then glucose levels normalize.
Right, so don't stop the insulin just because the sugar looks okay. Wait for the ketones and acidosis to clear.
Exactly. Resolution usually takes around 12–24 hours with effective treatment.
Okay. Are there specific things that mark out severe DKA needing more intensive care?
Yes, indicators of severe DKA often include very low pH, e.g. 7.1, low bicarbonate 5, high osmolality, significant electrolyte disturbance, especially potassium 3.5, low GCS, high ketones, 6, hypotension, or an anion gap 16. These patients often need HDU or ITU level care.
Good flags to know. What about special groups, elderly, pregnant, young adults?
Yeah, management needs tailoring. Elderly patients or those with heart or kidney failure might need more cautious fluid resuscitation to avoid overload. Pregnant women have specific considerations regarding targets and fetal well-being. Young adults 18 to 25 are at higher risk of cerebral edema, so need careful monitoring.
Okay, always consider the individual patient context. Now, thinking longer term, what's the prognosis like after a DKA episode?
With prompt, proper treatment in a hospital setting, the prognosis is generally good these days. As I said, mortality rates have fallen a lot, often less than 1% in specialist centers for uncomplicated cases.
That's really positive.
It is. However, prognosis is worse with increasing age, presence of severe comorbidities, like that triggering MI, or if treatment is delayed. Factors like deep coma on presentation, hypothermia, or persistent low urine output, oliguria, are poor prognostic signs.
And complications can still happen.
Yes, definitely. Cerebral edema is the most feared, especially in kids and young adults, though rare. It can be fatal. That's why neurological observations are so important.
What else?
The treatment itself can cause issues iatrogenic hypoglycemia if glucose isn't monitored carefully when dextrose is added, or iatrogenic hypokalemia if potassium isn't replaced adequately. Pulmonary edema can occur from fluid overload, arrhythmias from electrolyte shifts. There's an increased risk of blood clots, VTE, due to dehydration and immobility, so thromboprophylaxis is important. MI can be a cause or a complication. Acute kidney injury. ARDS, acute respiratory distress syndrome, is rare but serious. Hypophosphatemia can occur but rarely needs specific treatment.
So careful monitoring throughout is key to catching these early.
Absolutely. Vigilance is key.
Okay. And finally, how do we try and stop this happening again? Prevention strategies.
This comes back to education. For people with type 1 diabetes, structured education programs are vital. They need to understand sick day rules. What to do when they're ill, monitor glucose and ketones frequently, never stop insulin, they might even need more, maintain fluid intake, know when to seek urgent help.
Sick day rules crucial.
Definitely. They should have access to ketone testing strips. Blood is better than urine. Regular follow-up and support are important, especially for those with recurrent DKA, which might signal underlying psychological issues, adherence problems, or social difficulties that need addressing. And clinicians need to be cautious with drugs like SGLT2 inhibitors in high-risk individuals.
Empowering the patient seems central.
It really is. Good self-management skills are the best defense.
Fantastic. Okay, let's quickly summarize the absolute key takeaways for the MSRA. DKA, a life-threatening emergency. Remember the triad: hyperglycemia, ketosis, acidosis.
Triggered often by MIFT-in factors, especially missed insulin or infection in type 1 diabetes.
Diagnosis relies on blood glucose, blood ketones, and blood gas, showing acidosis. pH 7.3, bicarb 15. Remember, blood ketones, 3 millimole.
Management is FID. Fluids, 0.9% saline initially. Insulin, fixed-rate 5E infusion. Add dextrose when glucose drops. Electrolytes, watch potassium like a hawk. And treat the trigger.
Resolution means ketones 0.6, bicarb 15, pH 7.3, and clinical improvement. Watch for complications like cerebral edema, hyperkalemia, VTE.
And prevention hinges on patient education, sick day rules, and ketone monitoring.
Perfect. Hopefully using those mnemonics missed in and maybe APE's key will really help cement this for your exam. Understanding the why behind the steps makes it easier to recall too.
Absolutely. It's a complex process, but breaking it down logically helps manage it safely and effectively. Thinking about how patient education really can change outcomes is powerful too.
Definitely a thought to mull over. Well, we hope this deep dive has been incredibly useful for your DKA revision. For loads more free yield content and questions to get you MSRA ready, do check out passthemelio.com.
And don't forget freemealrate.com for some great free resources too.
Thanks for joining us. We'll catch you on the next deep dive.